Hello, and welcome to this episode of the Neurology Video Journal Club. Today we're going to be talking about exploring factors that prolong the diagnosis of myasthenia gravis that was published in Neurology. My name is Vera Bril. I'm a professor of neurology at the University of Toronto and the University Health Network. My career has been in neuromuscular disorders and particularly in myasthenia gravis, and I have studied the diagnosis, the monitoring, and the treatment of myasthenia gravis, trying for evidence-based approaches whenever possible. And today I'm joined by my co-discussant.
Hi, welcome to our session. I'm Carolina Barnett-Tapia. I'm an associate professor of neurology at the University of Toronto, and I'm also neuromuscular neurology, quite focused in myasthenia gravis. And I've been very interested in how can we improve outcomes for patients with myasthenia, from how we diagnose them to how we monitor them and how we find what are the things that are important for them. So thank you for having me.
All right, so the study that we're going to talk about is a retrospective cohort study done in Melbourne, Australia, at 3 hospital sites. The first author is Min Nguyen, and they evaluated 110 patients from 3 institutions and looked for reasons in diagnostic delay to try to identify where there may be holdups in making a diagnosis of myasthenia. We know from very old literature that if you don't treat myasthenia gravis for 7 years or so, that you have irreversible destruction of the postsynaptic membrane and fixed myopathy. So we want to avoid that at all costs. We want better outcomes. So we need to diagnose and treat myasthenia as soon as we can. And this study was an effort to look at factors that might lead us to be slow in diagnosis. Interestingly, the median time for diagnosis was 102 days, and 90% of their patients were diagnosed before 1 year. So they were nowhere near that 7-year cutoff. But Carolina, what did you think about the factors they identified that delayed diagnosis?
Yeah, so this is an interesting paper. I thought, the overall time to diagnosis was not as long as previously reported in the literature in many other places. So it could be that, for reasons related to their specific healthcare settings, they have, a faster way of patients reaching, appropriate diagnosis. In the factors that they identified, they did find that women took longer to be diagnosed than men by almost a 3-time-fold difference. So men were diagnosed roughly within 58 days, whereas it took women in median time 145 days. So that's almost 3 times more. And there's been literature before talking about some gender gaps in myasthenia, and women tend to have worse outcomes and worse disease severity. And you wonder whether that has to do with delay in diagnosis. At the same time, in this study, the authors found that women tended to seek care later than men. So from first symptom to first encounter with the healthcare system to, for that symptom, it took men, I believe it was about 14 days, and women around 31 days. So it was a little bit longer. However, it was not as long. You see, it was a 3-time difference from onset to diagnosis for women, but only 2 times difference in terms of time. So if it was just time to get a healthcare encounter and as the only factor, I would expect the curves to be kind of parallel, right? They start later by that time, but they diverge. They start at 2 times difference and then go up to a 3 times difference. So it seems to me that there might be some other factors related to gender that are not explored and we would need to look into.
Yeah, I think that would be very interesting. They did mention that they had not examined various factors that might contribute to women not seeking medical attention as quickly as men do, and that these issues are multifactorial in other conditions. So they don't have data on financial status, marital status, childcare, working. So we don't know about that. But the other thing I thought was really interesting was that people who were not working any longer and were staying at home also delayed seeking medical attention. And that seems to me unusual. I would think, if you had the extra time because you weren't working, that you could go and get medical attention faster. But not that was not the case in this particular study. Do you recall seeing that in other studies? I don't really recall that.
I don't recall, and the authors made some, some conclusions or some thoughts of why this could be, whether it is perhaps less access to go to healthcare, perhaps they're not driving, they need someone else to take them to healthcare. It may be, especially if ocular symptoms are the presenting, if you're not actively working, perhaps some double vision is not as disabling as if someone is active in the workforce and they may let it go. So there are lots of factors that we cannot know. And this is a retrospective study. So we know the time frames, but we don't know what motivated or did not motivate patients to seek care. We can only make assumptions.
I totally agree. And the other factors that I thought were quite interesting were the things that took longer to get to a neurologist was the presence of double vision, the presence of respiratory symptoms, or if they saw an ophthalmologist first. Now, I can see if they go through another specialist first, that delays them. They see that ophthalmologist, then they see a neurologist. And I guess a respirologist, they'd go to their family doctor, and maybe an internist or a respirologist, and then come to you. The double vision, I guess, the same. But these factors surprised me when I saw them because they're not readily explainable, right? They're not intuitive factors that might delay a neurological referral.
Yeah, I agree. It's hard to know. You see, if you look at the ancillary testing, a high number of patients, I believe 50%, if not more, had MRI of the brain. So clearly, there are some thoughts about potential cranial nerve palsies or other central nervous system problems. So it seems that some of these may not have been through neurologists or through some other specialties, and that may have delayed the diagnosis. But again, with the limitations of a retrospective study, we don't have all the data of how the patients presented and the sequence of events that led them to finally get a diagnosis.
I totally agree. The other thing I have to comment in general that the delays in our system may be quite a bit longer than the delays in the Australian system. Some of the time frames between when the test was ordered, when the result came back, when they saw a neurologist, and that were fairly rapid compared to what I think they are here. I mean, this may just represent the different healthcare systems, which I think it does represent the different healthcare systems. But I found that a little surprising, very surprising. I, um, in fact, and I thought, well, maybe we should be in Australia. I, I don't know. What did you think about that?
Besides the nicer weather in Australia compared to us in Canada, yes, I think it's probably very local. So this is not also reflective of all of Australia. So the study took three hospitals systems. So it's very focal. So, and I believe it's mostly Melbourne. So it really is focused on a specific, what seems an urban area. So it may not reflect the reality of people who are in rural centers who have to travel more. I would suspect that in that case, the numbers would be much longer. And the number is relatively low. It's only 110 patients out of 300 possible records that, some data were not available for analysis. So there's always some bias there that we don't know if this is a particularly rapidly assessed population and, may not reflect the reality of a larger healthcare system. But I agree with you. Those numbers, when I looked at the paper, I was impressed about how good they were. But having worked in other healthcare systems in other countries, I suspect they're not generalizable and really reflect a very specific, territory and a specific healthcare system.
Yeah, I totally agree with you. There were a few other surprising things to me in the paper. One was the high rate of generalization of the ocular patients within 2 years, which was much higher than a lot of others because presumably the patients were started on treatment within a year because most of them were diagnosed within a year. The authors make the point of how important it is to treat early to prevent generalization, because people with generalized myasthenia uh, present much more of a healthcare burden and cost than people with purely ocular symptoms. Because people with generalized weakness may have respiratory insufficiency, myasthenic crisis, hospitalizations, loss of work, loss of school. So I didn't, and I don't know. I think this is a small numbers probably as well, and also the retrospective nature of the study. What do you think?
Yeah, I agree. So it's, the range of generalization rates is broad, but this would be on the higher end of rate of published studies. Um, so, and what studies that have looked at patients who have received some sort of immunosuppression have seen lower rates. So again, there's no data regarding treatments in this paper because that was not the focus of the paper. So it's hard to know if that number reflects, treatment patterns or other factors. But I was also surprised a little bit um, that it was also a little bit on the higher end. The other thing that I thought it was interesting, but I would consider that we need to take a step back, is they didn't find, surprisingly, that the time to diagnosis made a difference in their final outcome. So the final outcome was using the MGFA category of remission, minimal manifestation status, improvement. So it's broad categories. And they didn't find that the time to diagnosis made a difference. But I would urge to be a little bit cautious because those, at least based on my read of the paper, were not adjusted findings. So they were just doing bivariate analysis, convert time by the outcomes. And we know that the outcomes depend on so many different factors. So you really need to adjust for, age of onset, like the gender, the treatments they have or not received, they have a thymoma or not. And I think it's hard to accept that without having all the other factors in the model to see, how they adjust with other confounding.
I'm not sure it supported their point that delaying diagnosis leads to worse outcomes. It did not in their patients, and maybe because they only had uh, just over 100, maybe because it was all from a few hospitals in Melbourne, but it didn't seem to really validate their point, right? And they seem to have very rapid intervention on in our eyes, but perhaps not in theirs. The other thing that I found interesting, and I thought a little different than I take, is they did say that paraclinical tests were not, totally sensitive. Well, there's nothing that's totally sensitive, but they were surprised that people weren't using the ice pack test and Kogan's lid twitch test more for the diagnosis. So I looked those up again because we don't use them. And the sensitivity and specificity of both of those are not that great either. I mean, if you have a very selected population, maybe. But I think made the interesting clinical point that if you're waiting, you might as well do these tests and they may guide you to a diagnosis. However, you're still going to do the antibodies. We're still going to do the single fiber and repetitive nerve stimulation studies. So I found that interesting, good for medical students, but I'm not sure how practical a suggestion it was. In fact, unless I'm doing teaching points, I actually don't do those tests anymore. And the neurologists seemed to get to the other tests they needed very quickly, like speed of light. They had maybe a day difference between inpatient and outpatient. I just said, wow, that's really something. Maybe that's something we could look at emulating, the ability to do such rapid referrals and assessments. What happens here with us is that the referring physician gets on the phone or says this is urgent and asks us to see the patient quickly, and we put them in, right? We bring the appointment up. But if that doesn't happen, if the referring physician isn't certain, then that patient will be waiting longer than 2 days or whatever the whatever the interval is. So, what do you think? Do you use these clinical tests routinely, Carolina?
I like you. I only usually use them when I'm teaching. They're very good. Sometimes in the ward when we see a patient, and if I don't have the electrophysiology machine there or the antibodies, it's useful then. But if I'm in clinic, and for those may have a different setting in our clinic, we have the electrophysiology, and we will do it right within part of the clinical encounter for a suspicion of myasthenia. So we would get the answer from the electrophysiological testing right then and there. So not as often, but yes, for teaching. And but again, I would not make a diagnosis based on just on a positive eyes test. I would always have confirmation. And in fact, for clinical trials, the criteria that become standardized usually do not include those tests.
Not at all. The other thing that I found interesting in their population was the really high rate of comorbidities, which is higher than I think in the general MG population we see, and particularly malignancies were somewhat high. Um, really, a little bit. History of malignancy in 16% of patients. I just thought that was a little bit high. And then they had multiple other comorbidities. And if I look at it here, neurologic disorders, like 24%, what would those be? Like how, and respiratory disorders, okay, 28%. Hypertension, that give them that. Um, but some of these things are really relatively high compared to our general population. So I I found that puzzling and wondered if it had introduced a bias, but not necessarily a bias that led to different outcomes in their study.
Yeah, no, that's true. It's we've looked at other studies, doing population based studies on myasthenia patients, and we've always found that when we match them to general population control, people with myasthenia often have more comorbidity, especially high blood pressure, hypertension, COPD. In the past, when we've looked at those studies, we've started when they were diagnosed, and part of our assumptions have been that part of our treatments are making them sick because prednisone and causing all the side effects. But in this study, these are comorbidities present at the time of diagnosis. So some of these patients were carrying these comorbidities, which is really interesting. So I don't know if there's some other factors playing or just a part of selection. They did have a number with autoimmune disorders, which is we know that people with autoimmune disorders are more likely to have other autoimmune disorders, so that is not as surprising. And I think with some of the other comorbidities may reflect our, late onset and very late onset people with myasthenia gravis that we're seeing. So for those in the audience who may not be as familiar with myasthenia, we always think, the typical young women and elder men. But in the past few years, we're having this cohort of people with myasthenia, with new onset myasthenia developing their 70s, 80s, and 90s. These are very late onset patients. And by nature of their age, they will have more comorbidities. So I wonder if some of this reflects that we're getting a population that's, getting myasthenia later in life, and they just carry more comorbidities based on that.
So the paper is really interesting. It raises several fantastic issues. Like, I mean, what is the delay to diagnosis in our world today? Uh, what happens with the patients? So far, nothing. But I would suggest they need more research. They need a prospective study and much larger numbers from many more centers, I think, to make the results generalizable. Um, and I'm not sure about the healthcare system in Australia, if it's unified across Australia, which means if it is, they might have to go to other countries as well with other systems to see what the delays are. Um, and I think I might be embarrassed if we did this study in Toronto, I in our center, because I have a feeling our numbers would be so much longer. What do you think?
I agree. I think I looked at some point of time, for other studies, and their time from onset to diagnosis is longer than this. They do make a point. They mention medians rather than means, and means may skew things as these are not, but normally distributed. But I'm feeling like going back and look at our data and see what we can learn from other places who are doing something much better than we are, and how we can improve outcomes, and diagnosis time for our patients.
So the difference, I think, too, is that we have no paths outside of our healthcare structure, right? There's no such thing as a public and a private uh, treatment option here. So really, the only way you expedite things is by calling and, you know, asking for favors and things like that. Otherwise, people are in the queue, right? They stand in queue. But I thought it was a very good paper and a very intriguing, raising a lot of interesting questions that can be answered by future work.
Yes, I agree. I think we focus a lot on new therapeutics and lots of fancy things, but sometimes going back to the basics and optimizing our healthcare and basic diagnostic strategies, that's a lot for patients. So I'm really happy to see this type of research, and congratulations for the authors for putting that together.
I would say the same. So, well, that's all we have to discuss about this article on exploring factors that prolong the diagnosis of myasthenia gravis. And thank you for listening to this episode of the Neurology Video Journal Club. And it was our pleasure to be with you. Thank you. Bye bye.
Thank you very much.